Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about 11 beta hydroxylase deficiency. And before we get into the deficiency, let's recap what 11 beta hydroxylase does in our pathway over here. You can see that 11 beta hydroxylase is active in both our mineralocorticoid and our glucocorticoid pathway. So it's going to be important for the synthesis of aldosterone and cortisol. And when we have a deficiency in 11 beta hydroxylase, that is subsequently going to lead to a deficiency in both of these end products of the mineralocorticoid and glucocorticoid pathway, meaning that we will have decreased aldosterone. We will also have decreased cortisol. One key aspect to note in this pathway, however, is that although we have decreased aldosterone, we are not actually mineralocorticoid deficient. This is because 11-deoxycorticosterone, which is the intermediate that 11-beta hydroxylase converts into corticosterone, still be synthesized in the case of 11-beta hydroxylase deficiency because we still have active 21-hydroxylase. So 21-hydroxylase is still functioning upstream of this pathway, and 11-deoxycorticosterone is actually going to be building up in excess behind the blockage in this pathway that occurs at the level of 11-beta hydroxylase. Since 11-beta hydroxylase is knocked out, everything behind it in the pathway is going to build up. We will see increased levels of deoxycorticosterone, which actually can still bind to that mineralocorticoid receptor and function much as aldosterone would, exerting similar effects, such as increased blood pressure, increased saving of sodium, and wasting of potassium in your kidneys. The increased mineralocorticoids in 11-beta hydroxylase deficiency, of course, 11-deoxycorticosterone is that increased mineralocorticoid, are also going to lead to increased potassium excretion, and the increased potassium excretion is going to lead to an alkalosis. So if you're asked about the acid-base status that would most likely occur with 11-beta hydroxylase deficiency on a step 1 question, make sure to know that it is alkalosis, not an acidosis in this case. Finally, you'll also see increased androgens. Since we can't complete the final steps in our mineralocorticoid or glucocorticoid pathway, everything is going to build up and eventually be shunted across this pathway. One of the results of shunting through these lateral pathways is that we are going to see increased levels of androgens as well. And these increased levels of androgens are going to lead to some of the characteristics that define the presentation of 11-beta hydroxylase deficiency. Our presentation of 11-beta hydroxylase deficiency is going to be hypertension resulting from the increased mineralocorticoids, mainly 11-deoxycorticosterone, hypokalemia, which we already talked about, increased wasting of potassium in the kidneys, and the symptoms of hypokalemia, such as fatigue, palpitations, and muscle cramps, can also be seen in this deficiency as well. The presentation that you should most be familiar with regards to 11-beta hydroxylase deficiency is the presentation in our XX individuals. So our XX individuals will have atypical external genitalia due to the increase in androgen. Because we have this increase in androgens, you're going to see some virilization in the female, which might lead to clitoral megaly or indeterminate external genitalia, or maybe even male appearing external genitalia. However, these patients will still have female internal genitalia because there is no anti-Müllerian hormone, there's no Y chromosome here, and even though there are increased androgens, this is not going to interfere with the internal development of these female structures, so you would still see a uterus, ovaries on ultrasound. The increased androgens can also lead to increased body hair, voice deepening, acne, all of these signs of virilization that you should associate with increased androgen levels in an XX patient. The effects of 11-beta hydroxylase deficiency are going to be much less pronounced in XY individuals. XY individuals will still have male-appearing external genitalia. The addition of some extra androgens in these patients isn't as big of a deal, so they might have precocious puberty, early beard, body hair growth, but nothing as stark as the differences in an XX individual with 11-beta hydroxylase deficiency. Now, the diagnostics of 11-beta hydroxylase deficiency are really important because they can help distinguish it from some of our other types of congenital adrenal hyperplasia. For example, something like 17-alpha hydroxylase deficiency in an XY patient might also present with ambiguous external genitalia. However, on ultrasound, if we were in 17-alpha hydroxylase deficiency, you would see a vagina ending in a blind pouch and no internal female structures, since of course this patient is XY. But in the case of 11-beta hydroxylase deficiency in an XX individual with ambiguous external genitalia, on ultrasound you would see typical female genitalia. That is going to be a key distinguishing factor. If you see typical female genitalia on an ultrasound, think that this is an XX patient rather than an XY patient. This would be a great way to decide whether you have a XX patient with 11-beta hydroxylase deficiency or an XY patient with 17-alpha hydroxylase deficiency on exam. And then some other helpful diagnostics here are decreased 11-beta hydroxylase. Certainly this enzyme that is deficient is going to be decreased in this case. Decreased cortisol, decreased aldosterone, increased sodium, and decreased potassium, with the addition of increased 11-deoxycorticosterone. And deoxycorticosterone and its impact on blood pressure is going to be important for you to remember in regards to 11-beta hydroxylase deficiency, because it can help you differentiate it from something like 21-alpha hydroxylase deficiency, in which you may also have an XX patient with ambiguous external genitalia, but an ultrasound showing typical female genitalia. However, I want you to remember that blood pressure would be normal or decreased if you're in salt wasting crisis in 21-alpha hydroxylase deficiency, but blood pressure would be increased due to this increase in 11-deoxycorticosterone in 11-beta hydroxylase deficiency, and that could be a key way to distinguish between these two on exam day. Management of 11-beta hydroxylase deficiency involves replacement of the hormones we're lacking, so hydrocortisone for glucocorticoid replacement. Remember, we do not need to replace our mineralocorticoids. You do not need to treat these patients with fludrocortisone, because even though they lack aldosterone, they still have 11-deoxycorticosterone doing the job of mineralocorticoid, and you do not need to replete these patients. They might actually be hypertensive. Additionally, there are surgical and hormonal interventions that are available to alter the appearance of external genitalia. Certainly, these are ethically controversial, depending on who is proposing them and the age of the patient, if the patient is able to decide for themselves or not. Now, to quickly recap what we talked about in this video using our memory tool over here, there's a 1 in the first column that corresponds to blood pressure. So blood pressure is going to be elevated in 11-beta hydroxylase deficiency. Remember that blood pressure is elevated as a result of 11-deoxycorticosterone. Aldosterone is actually going to be decreased, so important to remember that key fact. And then additionally, we have a 1 in the second column as well, so our androgens are going to be increased, and that is going to lead to our classic presentation of atypical external genitalia in our XX patient, but with typical female internal genitalia that you can see on ultrasound, maybe precocious puberty in XY patients. And some important labs are going to be decreased 11-beta hydroxylase and increased 11-deoxycorticosterone, which will be pretty unique to 11-beta hydroxylase deficiency and really helpful to distinguish it from some other types of congenital adrenal hyperplasia. Now, how'd they ask you about this on a board-style question? Well, something they might ask is, a 2-day-old infant presents with indeterminate external genitalia. Ultrasound reveals uterus and ovaries. Serum studies reveal elevated 11-deoxycorticosterone levels. What enzyme is likely deficient in this patient? Okay, so we know that this patient has indeterminate external genitalia, but it told us this patient has a uterus and ovaries on ultrasound. This sounds like typical female genitalia on ultrasound. However, an XX patient with ambiguous external genitalia and typical female genitalia on ultrasound could be a 21-hydroxylase patient. It could be an XX 11-beta hydroxylase deficiency patient. So we're going to have to figure out a way to separate between these two. One way could be if they mentioned the blood pressure. Remember, we would have decreased or normal blood pressure in 21-hydroxylase deficiency, but we will see elevated blood pressure in 11-beta hydroxylase deficiency. They didn't give us the blood pressure, but they did give us that 11-deoxycorticosterone levels were also increased. An increased 11-deoxycorticosterone would be seen in 11-beta hydroxylase deficiency, but it would not be seen in 21-hydroxylase deficiency, because if 21-hydroxylase is deficient and this intermediate comes below it in this pathway, it of course is not going to be synthesized at high levels. So because we have this elevated level of 11-deoxycorticosterone, we know that we are talking about 11-beta hydroxylase deficiency. The question asks us for the enzyme that's deficient, and that would be 11-beta hydroxylase, since that is the deficiency we're talking about. Now, I hope this video was helpful, and I'll see you next time.